He's going to lay on the table.
Okay, I'll lay on the back.
Okay, greater trochanter. Patient's position is prone, arms at the side. Doctor uses inferior hand, places it on the lateral aspect of iliac crest, points the fingers inferiorly down to palpate the greater trochanter. I'm going to let the patient bend his knee. Now he relaxes, and I passively, internally, externally rotate, and I can feel the greater trochanter move underneath my fingers. I've located the greater trochanter. Okay. I'm going to have my patient go ahead and turn supine, stay in the laying position, and we're going to palpate the medial structures of the knee. So I want the knee bent 70 to 90 degrees. The doctor is in a scissor stance at this particular angle so that he can get close to the knee. Fingers start in the popliteal fossa. Your starting place is the soft tissue space of the knee joint itself. So if I want to find the tibial plateau, I'm going to trace the infrapatellar ligament down to the bony prominence, which is the tibial plateau. To trace the patella itself, I would trace the patellar ligament up around the borders, define the patella itself to the most superior pole. I can feel the intracondylar groove, but if I straighten the leg out, I can slightly move the patella down, and I can actually feel the boundaries of the medial and lateral condyle forming that trochlear groove. Okay. Back to the joint space, and now what I'm going to identify is the adductor tubercle. And so from a standing position, it's actually going to be in a superior direction, directly superior to the medial epicondyle. But from this position, we're going to come up above with our medial hand, identify the medial condyle, go on out more medial to the medial epicondyle, and continue anatomically superior until I feel that ridge that's formed where the adductor is attached, so the adductor tubercle right there. Next will be structures on the lateral side of the knee, so I'm just going to switch knees so we can see. Again, doctor stance close to the extremity, fingers in the popliteal fossa. And now what I'm going to do is trace the tibial plateau to its most lateral aspect, and then from here I'm going to slide slightly inferior, and you'll feel a ridge right there just below the plateau, and that is actually Gerdy's tubercle, where the tensor fasciolatum muscle attaches. Directly inferior to that, we should find the head of the fibula. And so I'm going to take a pincer type contact, stabilize the tibia, and I'm going to use my body and my hand, and I'm going to move that fibula in the A to P and P to A direction. I've identified the fibular head. Next, we're going to move on down to the foot and ankle. So since I'm on this lateral side, I'm going to start with the lateral structures in the foot and the ankle. And so to do so, I'm going to hold the medial side so that the lateral side is completely available. And so I like to kind of rest my elbow on my leg because the foot's heavy, and we're going to be doing some palpation here that's going to involve some distraction. So on the lateral side, what I'm going to find is the cuboid, the peroneal tubercle, and the calcaneus. So to get to the cuboid, I'm going to trace the 5th digit back to the base, to the styloid process. I'm going to go posterior and medial, and this large structure right here is the cuboid. So I'm going to take my thumb on the top of it, my index finger on the bottom of it, and I'm going to get a hold of as much of the foot as I possibly can, and I'm going to move that cuboid up and down. You have to stabilize the rest of the foot, otherwise this is what happens. So stabilization up and down. Continue on back in alignment with the lateral malleolus. About midway to the calcaneus, you'll feel that peroneal tubercle right there. Continue on back to the calcaneus. Take a cup grip on the calcaneus. Stabilize the rest of the foot, particularly the talus, and you're going to use your body weight and distract the calcaneus inferiorly, and then when you release it, it goes back superior. Still distracted, I'm going to invert, evert, and I'm going to do an A to P glide. If I didn't stabilize the foot, this is what would be happening. But I've got that talus in the foot, so a lot of distraction. And as you can tell, it takes a little bit of effort. Now, structures on the medial side of the foot. So to expose the medial side of the foot and palpate, I'm going to hold the lateral side of the foot just like this, elevated off of the table. I'm going to find the medial malleolus, which is right here. Immediately below that is the body of the talus. Talus is a very big structure, and remember, it is part of the mortise joint. It's what the actual tibia and fibula sit down on top of to allow dorsiflexion. So there's a body of the talus. I'm going to follow the body over to the top of the foot with my thumb, and now I'm on the dome of the talus. And now what I'm going to do is dorsiflex the foot and plantar flex, dorsiflex, and I'm feeling that talus dome rock into that mortise joint. When it's stuck, you will have decreased dorsiflexion, and you won't have that spring of the actual talus going into the joint. Now that I've located the talus, just switch hands, put my thumb over the dome of the talus, and the next structure that I come to immediately below that is the navicular. Keystone of the arch. So you go into the deepest part of the arch, and this one you really have to get a good hold on. Take your index finger, pith on the bottom of the arch, take your thumb on the top, hold on to that talus, and you can see I'm right next to the talus, and then you're going to palpate that navicular up and down. If I don't hold the talus, the foot moves. So you always are stabilizing something proximal. Now, move down to the navicular, and I have the cuneiforms that articulate with the navicular. So my stabilization here is now on the navicular bone. Take that pincer type palpation, palpate the medial, intermediate, and lateral cuneiforms. And don't anticipate much movement on these at all, particularly the intermediate. It is at the highest part of that transverse arch, and there's hardly any movement, but there should be a little bit. So the key is stabilizing the bones around so that you can isolate and palpate. We have one more structure. So we found the body of the talus. Continue on inferiorly, and you're going to feel a little tubercle. It's called the sustentaculum tali, and it's actually on the calcaneus. That's where the round ligament goes from there to the navicular, so it's real important in the stabilization of this longitudinal arch. So sustentaculum tali. Okay, lower extremity.
To a point, but it didn't fix anything. It didn't